for the Billings Transitions Coalition. And this morning we have the good fortune of having two people, not just one, but two people, Karen Walker and Melanie Bullock from the Veterans Administration, to talk to us about how the Veterans Administration fits into the continuum of care for veterans. And I want to remind all of you to please log in with your name and organization on the chat screen. And as we go through this, please enter your questions so we can present those in a more orderly way when they're done. So Karen, I understand you're going to go first, so the floor is yours.
Okay, well, welcome. Thank you everyone for joining us bright and early this morning, and especially thank you for your interest in the Veterans Administration and our veterans. We're going to start with an overview of the whole model of care that the VA, start with an overview of the whole VA system and then talk a little bit about the model of care that the VA uses. And then Melanie will take those individually and break those down for you. And then we'll kind of summarize at the end. So, many people know veterans, have veterans in their family, and even so, the VA can seem like a different kind of place, a whole different culture, a whole different atmosphere. And it is in some ways. What makes veterans and the VA unique is that we have this common bond of our experience as veterans when we served. And that's a unique experience, not that most people have. I don't know that anybody else can say that isn't a veteran, that they've fired a light anti-tank weapon or threw a hand grenade or run more miles than they care to. But so that's but given so, we think about going into the hospital or any other atmosphere where we're unfamiliar. We're healthcare. The biggest thing about the VA to remember is that it's a benefit rather than a health insurance. And your benefit is based on your time in service and where you served and how you served. So there's so many variables. So people say, well, he's a veteran, he should be able to or she's a veteran, she needs this, and they should be able to, or my friend got this. Well, it's also very individual. And when we think about the VA as a whole, we think about it from like three business silos, is the best way that I can put it, is veterans benefits. And that's the branch of the VA that processes people's paperwork when they leave, and it's responsible for their benefits and their death benefits and their service connected rating. We hear a lot about people 10% for service connected for hearing or 20% for that. And that's one of those variables that will determine your healthcare options. But it's important to remember that benefits is all done through VBA, Veterans Benefits Administration. And they do have an office in Billings on the MSU campus in the education building. And then we do have an office right over here at the VA, which, if you don't know, is over off of Zoo Drive and Shiloh. And there's two separate buildings. One is specialty care and one is regular care. But we have an office over there for veterans benefits. So we can answer a few questions. There's three of us social workers, and we can answer a few questions, but generally we'll defer you to veterans benefits because it's ever changing. And that's why it's important that people re-look at their VA benefit. That's not just a one-time stamp all. And the best example I can use is, well, right now is the Camp Lejeune water. People that served at Camp Lejeune in a specific period of time and were exposed to the water have these benefits based on the contamination that occurred during the water, from the water. The other one is Gulf War syndrome. Many people remember back at the Gulf War, veterans were coming back and they had very vague flu-like symptoms that really weren't matching with anything. And these were young, healthy people that shouldn't be experiencing these symptoms. And it wasn't until later on when they compiled enough data in order to define it that these people at this period in time experienced these symptoms, and then they have what's called Gulf War syndrome. So Agent Orange is another one. So there's many of them, and that's all associated with veterans benefits. So I'll leave that alone. And then Melanie and I and Carissa, as our other social worker, we work for veterans healthcare. And that's the primary care where people go to get their health care. And again, their benefit of health care. And your benefit of health care is determined partly on when you served, but there's also an income test that has to be done. And that kind of goes along with, late in World War II, those veterans were very successful people as they grew up and then with the Vietnam veterans coming by, there was an influx of veterans using the system. And it's important to remember that because it's a benefit, our budget is determined by Congress. And so when you're thinking about voting, that's one thing to consider, that what is their perspective on veterans? Because one administration to the next, or one cycle to the next, can depend on what benefits may or may not be available. So there's just a lot of different variables that go into that. So, but at veterans healthcare is where they receive primary care, like going to your regular doctor. And, I don't really know where all of you are from, but I've been in healthcare for more years than I care to count. And it's just a wonderful time. Here at the VA, we have access to your primary doctor and a team, which I'll go into a little more, but you also have on-site the dietitian, a pharmacist, primary mental health, a social workers, and then the clerical support that does so good at supporting us. So, and that's all in one visit. And I think that's the way the civilian sector is going to a little bit too. But at the VA, we operate under what's called a PACT model of care, primary aligned care team. And so each person, you have your primary provider, whether it's an MD or an NP. We don't really have any PAs at the time, but we haven't had in the past. And then you come in, and the team is comprised of the provider, the RN, the LPN, and an MSA, our clerical support. And then each of us social workers are assigned to various teams. The teams all uniquely have names. So somebody might say that they're assigned to a Blue Jay team. And one of the reasons I think they did that, this is in fact, is because we do have providers that come and go. We do have quite a bit of turnover. And so that, designates you're on that team. But anyway, so that's on the team. So when you come in and you make your appointment, you see your team, and they're responsible for your care in the same way that you would be in the civilian sector. And we as social workers then, rightly as our profession, kind of see the whole picture and put it together and kind of help the veterans navigate the system and understand. We provide a lot of advanced care planning training, as Melanie will go into, about home health and other benefits while they're there. And then the last silo is the cemetery, and that's a separate department all in its own. Again, when I said from a business perspective, you've got these three areas. The cemetery is pretty separate. Veterans benefits and veterans healthcare, we overlap, but our systems don't communicate. So what veterans benefit can see in their computer and what we can see in our computer, and rightly so. You wouldn't want somebody determining your benefit that had access to your healthcare record, all of it. You want to be able to request those records that are going to reflect what benefit they're, a need to know. We all know about that, a need to know. So that's a little bit about the overview of the VA. We have, in our primary care, in our specialty care, we have our X-ray department, we have a full functioning lab, we have neurology, cardiology, podiatry. I'm trying to think of what else is over there. We have a surgery center where we do endoscopies and things like that. So it's really quite a complex that we offer a lot of things to the veterans. Can you think of anything else I'm missing, Melanie?
No, you're doing an excellent job covering everything.
Okay, so I know what else I wanted to say. Okay. I think we have 10 primary care providers and 8 different PAC teams. So that's pretty large. Each team, the 100% panel size is 2,500. everybody runs probably what, up 125% or higher. So it's a pretty large group of population that we serve, and we serve all the way, into Wyoming up to Polson and Plentywood and Havre and Glendive and Lewistown. So, I mean, that's across the state, and across the state, there is 19 social workers now, I think, at our full complement. And so we're growing and providing services to everybody, and just enjoying our job. It's just one of those things people say, it's hard work, as we all do when we work with these populations. But at the same time, when someone comes to you and says, my dad's a veteran and he needs help, and you can in any way, relieve some of that burden, it's a good day, and my heart is full. So I'll let Melanie take it away, and I'm going to go grab some water.
Okay,
Karen.
thanks, Karen. I wanted to touch on, I'll start with, we get this a lot, so I wanted to touch on VA home health care, so which is non-skilled services. So that would be agency-based services, providing, so the VA, sometimes some people think, oh, well, I need assistance cooking, or, I can't mop my floors, and those would be housekeeping services. And so the VA, we currently don't cover for housekeeping services. We only cover currently for personal care needs, for ADL needs. And those would be dressing, grooming, bathing, eating, somebody needs assistance eating, bed mobility, getting in and out of the bed, transferring out of a chair, assistance walking. It could be somebody with some, behavioral problems due to, diagnoses of dementia. And also, we look at that too. Also, if they have a diagnosis and if they have, memory loss. So that's considered into the factors. So basically, to determine this, a veteran, first off, we'll get many calls from the hospitals or the home health agencies. My dad or this veteran needs, a home health aide, and we'll look them up in the system based on their social security number and last name. And many times we'll find like they're not even in our system. So first off, a veteran needs to be enrolled with the VA, and you would think it would be, universal, but it's not. It's state by state. So if they just moved here from Colorado, they're not going to be in our system. They would have to enroll with Montana VA. And enrollment's a simple process. You can do it online, which many people can find can be a little more confusing. So you can do it in person and just come to the business office. It's just a matter of paperwork. And then, they would set up a primary care physician appointment. So their first appointment to get established with a provider here. And once they do that, they would be eligible for different services. Now their copays would be based. So when they do that enrollment process, some of the paperwork is income information. So whether they have a copay and the amount or no copay at all is based off that enrollment paperwork. So, and that kind of piece is done with the business office. We don't, in the clinic, we don't deal so much with the logistics of the income and billing. But how it would work from there is they'd see their primary care physician. They could request this ahead of time or at their primary care appointment, or we may get a pre-request from the hospital or, home health agency or so forth, that they need home health. And so we would have the primary care physician RN do what's called a nursing GEC, a nursing geriatric assessment. And that basically touches on, it's an overview of, if they have any personal care ADL needs. And so from there, once the RN spends time with them and determines their ADL needs, then it gets bumped to the social worker that covers for that provider. And then as social workers, we would determine eligibility, excuse me, for a home health aide. And we wouldn't just look at the assessment by the nurse, we would do our own clinical assessment. And we would also look at IADLs, which are the housekeeping services. And even though we don't cover that, we still want to determine, you know, like what's their abilities in those areas as well. What's their cognitive functioning, because they could have more, as an example, lower ADL needs, but a diagnosis of dementia, which, you know, makes it very difficult for them to function on their own in their own home. I will say as a side note right now, so we have various VA contracted agencies within Billings and the surrounding area, well, throughout the whole state, but right here, you know, in Billings, there's X amount of agencies that are contracted with us. And the problem is right now, and in a lot of businesses, there's a lack of staff. So even if we do these different assessments right now, we're struggling because we'll contact various agencies, and it changes day by day. The agencies are having a hard time maintaining adequate staff. So obviously, if they can't, then they are unable to accept more veterans. And we're hoping, obviously, in the future that changes. But it changes day by day. They're obviously working hard to try and get new staff. Their home health hours, it varies. I would say an average could be approximately 9 hours. It could be a little less, and that would be weekly. And it could be a little less, it could be a little more. And once the nurse does her assessment, the social workers do our clinical assessment, then we would determine if they meet eligibility, inform the veteran, and from there it gets bumped to Fort Harrison, who does the contracts with the agency, and the veteran from there would have their first initial assessment meeting with the agency. And how those hours would work out during the week is the veteran would work those hours out with the agency themselves, what works best, and what the agency can do and what the veteran needs, whether that's let's say 10 hours and spaced out 2 hours within 5 days a week. That contract is currently, it used to be 6 months, and now it is good for 365 days, which is really good, that it's lasting longer. I will say the nursing assessment, many times we'll get calls and they just want to do it over the phone, but right now they're requiring that those nursing assessments either be done face-to-face, or if for some reason the veteran cannot make it physically into the clinic, that they do a veteran video connect appointment so they can lay eyes on the patient and, basically see, physically how they're doing. And let's see. And then another thing, I can definitely take questions on that more further. Another program we have within the VA, it's the same. It's for based on ADL needs, but it's based on extensive ADL needs, and it's called veteran-directed care. Veteran-directed care would be the same process. They would need to have an assessment face-to-face with an RN or VVC, same thing, clinical assessment from the social worker. The veteran-directed care is, again, it's based on extensive ADL needs. So they need to have, be determined that they're struggling with many ADLs. And also another determining factor is basically not live within agency-based services. So it's ideal for many of our rural veterans who live where there's no agency-based services. Or another consideration is when all other options have been considered. And that is a as-need basis. That's more of a not so automatic, but more of the social worker advocating for the veteran. Look, they live in a rural area. they have extensive ADL needs, kind of presenting it to the HCBS team up at Fort Harrison and just saying, hey, this is going to be the only option that this veteran has, really needs assistance. And so their caregivers are, it could be a family member, it could be a neighbor, it's not, necessarily, it can be an agency worker, but, someone at a distance that's willing to drive farther. But those services would be, it's a monetary factor. So there would be a certain amount of money tied to based on their ADL needs. And that program is case managed by, it's called Area 2 Agency on Aging, and they case manage the program. And so from after it's all said and done, and we do our assessments and approve, it goes to Area 2 Agency who case manages the program for the veteran and for the caregiver to make sure everything's running smoothly. That is now running at 365-day authorizations as well. So that's another option, because as you can imagine, within Montana, we have many veterans that live in rural communities, many aging veterans, especially living in rural communities, who are needing assistance. Another program the VA offers is Respite Services. And for those who are not familiar with Respite Services could be, it could be a spouse is the primary caregiver for a veteran. He's got a diagnosis of dementia. She needs a little time here and there to get out to the grocery store, to attend church, to just to maybe even have a nap or a mental break. That could be something, as an example, that Respite Services could be used for. And Respite Services can be provided in the home, and they can also be provided in a skilled nursing facility. That would be a VA contracted skilled nursing facility. And currently, it's approved for 15 days, no more. So 15 days every 6 months, and no more than 6 hours a day. So obviously, if they're in a skilled nursing facility, that's different. But if they're using a contracted home health agency, they could use up to 6 hours a day for up to 15 days in a 6-month period. And then, so it's no more than 30 days in a calendar year. And again, that respite actually is the same process with a geriatric assessment in the clinic, and the social worker assessment, and then the same thing, authorizations done by Fort Harrison. It's basically the same process to determine the respite and determine if it's right for the veteran and the veteran's family. Respite obviously is a major consideration as the caregiver who's primarily caring for the veteran, and needs a little break on that. Another thing I want to touch on is we get many questions. Montana VA, so skilled nursing facilities. Skilled nursing facilities, we contract with X amount of skilled nursing facilities within the state, but I'm speaking for now, like Billings and the surrounding area as an example. We just actually added 3 more contracts with 3 more skilled nursing facilities. So that's really good. Before we had limited options. A major thing, like people sadly will say, I get calls from veterans or from their family members. Okay, I'm a veteran. I'm ready to go to go live in the nursing home now. Well, it's for eligibility for a VA contracted nursing facility, you have to be 70% service connected or higher. And again, that service connected rating, as Karen was saying, is related to the Veterans Benefits Administration. And it's based on their injuries or illnesses which occurred during their time in the military, and injuries, illnesses, disabilities that are sustained now. And so we, as social workers, we would we would look at their service-connected disability rating to determine if they're eligible for a VA contracted nursing home. Another factor that can be considered, if the veteran is on hospice, we can also obtain a VA contracted nursing, skilled nursing facility, long-term care contract for the veteran if they're on hospice services. That care is 24 hours a day, 7 days a week. There's no additional costs, anything they need, whether, bandage, medications, you name it. It's all in the whole package of the VA picking up the tab if they are on hospice services or if they were 70% service connected or higher. So that is a little touch on some of those things. Wondering if anybody has any questions or if I should just go ahead and look at the chat, Dave.
I'll help you out with that so that you can.
Okay.
I'll ask both of you and Karen. Karen's been answering some of the questions, but for the benefit of everyone, I'd like to have you feel free to elaborate.
Sure, of course. Let me go on.
Veteran use standard Medicaid benefits for home health along with VA benefits.
Oh, so you're talking like a PALS program, like patient personal care assistance and VA?
Yes,
Are you-
community first choice, and then the VA
Yeah.
benefits. Yep.
Yeah, so old school. So yes, they can. And I have had veterans that do that. You have to be very careful about the overlap, because the community first choice has my understanding, a little more lax on the IADLs. It's a little more expansive than the VA is so focused on ADL needs. They have to have, as Melanie said, a personal care need in order to qualify for the program. So we can have the community first choice going in and providing a bath, and then the VA aide coming in and doing the laundry. So it can be, the coordination of it is just, it just takes a lot of coordination. But that's the big issue, is that they can't have overlapping in care. Does that make sense?
It does. Thank you.
Mm-hmm.
You've already answered this online, Karen, but it says, do the nursing assessments go to the vet, or do they have to come to the clinic?
Melanie, you want to take that one?
The nursing assessments, when they come to the clinic, as I said, they meet with the RN to do the geriatric nursing assessment. And from there, the assessment goes to the social worker, so we can contact the veteran and do our clinical piece of it, and do our assessment. There's nothing hidden from the veteran by any means. We'll discuss, the factors that of the ADLs and that were triggered, I should say, triggered, or their ADL needs, but no, but yeah, so no,
Yeah,
it comes to the clinic.
Yeah,
ahead,
and it can be done by video, as Melanie
Yes.
said. But one of the reasons that we want it face-to-face is we want to do more of a comprehensive assessment. We want to really look at what their support systems are, what their long-term care plan is, what their financial situation is, get some history on why they're where they're at and what their goals of care are, for the future. And as I said, their advanced directives. And so that's why it's based, it's a more comprehensive assessment, and that's why the social worker gets involved. That geriatric extended care, the GEC assessment is, done by the skilled nurse. That's the skill set for the registered nurse. And then we see them and interpret that and do a broader assessment.
And for those of you that are looking, Alana asked a question, and there's been an exchange of information. There's some priorities care link on the screen, and I'll make sure I send that out to everybody. But do you want to talk a little bit about that, the website information that's highlighted there, Karen or
Sure.
Melanie?
Yeah, there's the website that when Melanie was talking about enrollment, and I'll just kind of spin off of that. many veterans don't enroll when they come back, and especially our geriatric veterans. They, oh, I don't need it. Somebody else needs it more. They just were so selfless. But you can enroll anytime. We have many people, right, Melanie, that, enroll, get home health, transfer to the nursing home, or transfer to hospice and transfer to the nursing home, and die all in 6 weeks.
Yeah.
So it can happen all rather quickly, and everybody's encouraged to enroll. If I would say to our audience out there, what I would like to see to be a veteran-centric organization, and somebody asked something about patient care priorities, and that's on the website, but to be more aware is within your admission process in whatever organization you're working for, that you have a mechanism to identify veterans as part of the admission process. What's your address, what's your date of birth, are you a veteran, and have you been in contact with the VA? The hospice organizations have a program called We Honor Veterans. And last time, it's been a while, Melanie and I both came from hospice. That program was going to expand into not outside of hospice. So that's a website people could look at, but that was part of their process. Putting a, everything's putting a process into place, and so we don't miss it, and identifying the veterans. If for no other reason, then you can acknowledge their veteran service. And it's just tells you have a level of care beyond what your initial scope is that you're there for. So that's where the website comes into play. And the VA is very web friendly, as many complicated things are. Like Melanie talked about enrollment, and the form for that is called 1010EZ. And you can type in VA form 1010EZ into any Google search engine, Bling or Bing, or whichever engine you want, and a PDF generally will come up on that. The website is full of a lot of information about veterans benefits, all those different service connected illnesses, like I was talking about, like Camp Lejeune. You can Google that. So, I was actually working with my daughter. We've all been homesick in her homework, and she had a question. And I said, well, just phrase the teacher's thing as a question. So, type into the search engine, veteran served during, the Gulf War and has, a rash, and see what comes up. But the VA website is really worth it while taking a little time to go around. Lots of educational materials out there. And that's another thing is that we, provide and broker with area, agencies in the community about where to get stuff. I partner with the Alzheimer's Association, and we provide some veteran-centric Alzheimer's education and support. And so, yeah.
You want to add anything to that, Melanie?
No, Karen did good.
Okay.
I was reading through the questions. I was like, did we answer the how does VA medical and Medicare work for hospice? Did we touch on that, Karen?
No, go ahead. Yeah.
Okay. I was going to just touch on that. So basically, when I was saying about a veteran, admitting to hospice services, generally, as Karen said, both of us come from a hospice background as well. So we do have some knowledge on that. So the veteran at the hospice agency would be given a choice. They could use their VA benefits, for example, or they could use their Medicare benefits. Many times, I would say more often than not, a veteran will just choose to use their Medicare benefits. It doesn't matter either way, whether they choose Medicare or VA for coverage. An example where they might choose the VA would be somebody obviously that is under 65 years of age that doesn't have Medicare. That would be, if it's somebody, obviously they would need to be well established with the primary care physician, or we could go other routes as far as having the virtual PAC team over at Fort Harrison, review their case and the clinical notes from the hospice agency and their diagnosis. And that's how, as far as VA and Medicare, as far as hospice goes, unless Karen wants to add onto that.
No.
Yeah, okay.
No, that sounds great. They can choose whether they want to have VA or Medicare billed, but yeah, every veteran has a hospice benefit, as Melanie said. Then we have a question, and it's a good question from John about if a veteran has a certain percentage of service connection, so as I said, like 10% for hearing, that one's just so common. Are they ever able to reevaluate for an increase of and more services? Yes, at any time in their life, or a disability evaluation. Yes, their evaluation, disability can be evaluated. Where do they start the process? And that's through veterans benefits. That is what does that evaluation and determines your service connected and researches your medical records and your time of service and where you served and what was going on there. And like I said, all those different illnesses that kind of come up over time once they collect data. So it's great to encourage people to have their service connection reevaluated. You were 28, 26 when you got out, and now you're 66, and things are a little different. I don't want to go too much into it, but that's again why it's always nice to identify somebody as a veteran in the admission process, and if they've been in contact with the VA, because there is some low income benefits for our poverty veterans. There are some other, there's always little caveats, outliers of benefits. And so it would give each of us a call. We put our numbers on the PowerPoint. When you run across a veteran and have a question, we're more than welcome to direct you to, where in the system we can navigate things or to help out. And I'll get veterans benefits number and put it out in the chat there.
So can you help me understand what's the relationship between the Veterans Administration operation in Billings and Fort Harrison? Are they regional service entities, or is there a hierarchy between the two of them?
Yeah. So the Fort Harrison's our mothership. So it's the hospital. It's where it used to be in Miles City for those that have been around for a long time. But yeah, so we refer to it as our mothership. So it's where all our administration offices are, but it is a functioning hospital too. I think it's a 22-bed hospital, provides lots of surgeries and different things. It's on the in Helena on the Fort Harrison campus there outside of town, on the west side after you go through East Helena. So it's kind of where all our funding comes, where everything comes from. All the policies come down from there. So I guess it would be kind of like Sisters of Charity of Leavenworth in Kansas, and then St. Vincent's. Does that help make sense?
Yep, it does. And I have a question. I'm going to go back to something that I think you mentioned, Karen. If a veteran applies for benefits in Colorado initially and then relocate, let's say, to Montana, I want to go back to this question about the reevaluation. If they're assessed in Colorado and move to Montana, does that information follow them? Can you access it any way at all? Or do you have to start completely over with your own assessment here in Montana?
You go ahead.
Me. There is a way we can see some medical information from their past teams from other states, but no, they would need to reestablish, re-enroll. They would need to enroll with Montana, and we would need to redo the assessments with Montana. So that it would all be establishing with the providers here. So yes, unfortunately, all those things need to be repeated,
So from a network kind of perspective, back to that business model, the VA is broken down into those three silos that I mentioned. But within veterans healthcare, there's all these different VISNs. And we're in VISN 19, which covers Oklahoma, Colorado, Montana. And I can't think of anyway, but so that's like a puzzle piece, a map of the United States and all these different VISNs. And funding comes from Congress to that VISN. And then so we get, $1 million at VISN 19, and then it's broken down out and dispersed throughout the VISN. So what is happening in budgetary wise for one VISN isn't necessarily for another VISN. So it's a little easier within VISNs, keep saying that word, but it's a budgetary wise, they have to re-enroll, or not re-enroll, but they have to establish with a primary care. And that's kind of like if you moved from Billings to Colorado, you would need to get a new primary care doctor. They would need to find out your records, so it's not it's not that odd, but people think because it's the VA that everything is more fluid, and we wish it was, but it's not.
Yeah.
Mhm.
Those of you that we've answered questions, if you have a follow-up question, don't hesitate to just chime in verbally. There's no need to enter that. There's a question here from Mike, and I'm going to ask Mike to clarify this because it says, can you clarify the Southwest contact?
Oh, he's one of our PAC social workers. I think he wanted, can you clarify that we as social workers contact the veteran and do our portion of it, which we have now touched on, that we contact the veteran and do our clinical assessment after they had the nursing geriatric assessment with the nurse. So that's, I believe, what Mike was speaking of.
That's correct. That's what I was asking. Thank you.
Okay, thanks, Mike.
Yeah, you can access the VA. You know, you can just call any of us and access the VA, and we'll kind of direct you, or just call into the VA. You know, over here it's 373-3500, and you'll get a call center, and they can direct you, and then, or each of us individually. But yeah, we're happy to help you get enrolled, help in any way.
So for my benefit and maybe a few other people, tell me about, is the operation in Billings, you described an array of services that you provide. It sounds like it's pretty much a standalone operation except for some very specialized services. Is that a correct assessment?
Yeah, I would say that, it's pretty all encompassing. Yeah, I mean, I'm trying to think of what, we don't have like rheumatology, we don't have, allergies, some of those real subspecialties, but for the most, all the big ones. And just to touch on that, then if we don't have access to that, we can do what's called care in the community and refer people out. Our vision, we don't have vision. That would be a good example of people go out and get their glasses, and you have to see your provider, and everything runs on what's called a consult. And so the order's written, and then the authorization goes to the providing source, whether it be orthopedics or vision, and then you make your appointment there. The appointment is scheduled through scheduling. So it's a little bit of a process, but yeah, so that's again why there is always encourage people to call, because there just always is all these little veins and avenues of accessing things, or not. I mean, there's lots of times when we don't have a service that like is available, and what we can try and figure out how to help you. But that's what we're here for.
On that same topic, Karen, just curious, because I'm familiar with Indian Health Service and kind of the referral, the purchase referred care process. Is it similar to that, where you have preferred external providers to refer to, or is it just, you just have to make that contact? And
Yeah, that's a good question. As far as home health, we have contracted services, but if I don't believe it's like a preferred provider, it's more availability. So like if you wanted to go to Ortho Montana versus, I don't know what other, you want to go to Radar versus XYZ hearing clinic. I think it's more a personal choice, but I'm not 100% sure. But I know that it's not like a PPP. We don't have a network of physicians that we are in our network that we would refer to, and there wouldn't be an out of network versus in network status.
great, thank you.
We've had Ben Terrell from Big Sky Care Connect talk to us about the health information exchange system that we are developing in Montana. This may go outside of your domain, but when a patient's referred out, are those records capable of being transferred electronically to the provider when you do make those referrals?
Yeah, I think I would defer on that. I think we'd have to address it each individually. We don't have, like we can see the hospital records. We have access to their charts, and we have access to some of the nursing home charts. But I'm going to say no. I don't. That outside of my domain.
Okay.
Melanie.
Sorry, I was answering a question. No.
Okay.
Mhm.
There's lots of you out there. Please feel free to chime in with follow-up questions, or I think we've covered everything that's on the list here. Anybody have any questions? Talk to us, what are the most important takeaways for those of us that are on the phone? If you were going to tell us, boy, don't forget these 3 things about the VA, what would you want to tell us?
Oh,
Important
okay.
things on a day-to-day basis. I'm gonna let each one of you give each of you 3 questions or 3 shots at this. So
Get
Join-
enrolled. Get enrolled. I run
Yes.
across these young veterans that come in, and I say, go get enrolled. You have to come to the VA once a year to maintain your enrollment. And you just never know when life will throw you a curve and you'll need that benefit. So get enrolled would be my very first thing.
Okay.
Yeah. I'll add to what Karen said too, and is to update information. I mean, we'll have veterans sometimes that, you know, perhaps they have a copay, but when they initially enrolled, it was 20 years ago and their income was quite a bit different. They were working full time and now they're retired, their income's more limited. So, you know, update, you know, keep information updated, you know, it can only help them, you know, and they're, you know, maybe don't have a copay any longer, you know, so it could financially help them.
And what drives that copay? You've mentioned that a couple of times. Related to the illness or disability of the service rating? Or is that a separate tested or what?
It's not something we handle, but it is related, and certainly Karen, correct me if I'm wrong, but related to the enrollment paperwork, and there's an income piece to the enrollment paperwork. And so their copay would be related to the income piece on their enrollment paperwork, whether they have a copay or no copay or whatever the copay amount is.
So
Yeah,
it's
it's driven.
subject to change based on their income then, is that correct?
Yeah. So, you know, that's why it's crucial that they keep it, you know, information updated. And, you know, it's surprising sometimes how long it can be. Like I said, I've seen many veterans be, well, shoot, I'll look back and well, oh, it was 1983 when they enrolled. And like I said, they were making a lot of money. They were working and now they're retired and living off Social Security and their income has changed drastically. And so, you know, that'll be something, you know, I recommend to, you know, the veteran and the spouse is to have the veteran, you know, update that, you know, information with the business office.
Anything else you'd like to say, Karen? Another takeaway?
No, just reach out to us, you know, call and put your process in place to identify veterans.
Okay.
That's the
Anybody else out there have any questions that they'd like to direct? Well, with that, I want to thank both you, Karen, and you, Mel,
Hey.
for joining us this morning.
Thank you, Dave.
Very good presentation. I'm going to share your contact information that's been on the screen here in the minutes. And if you have any links or anything that you'd like me to provide, there's some in the information here, please email them to me and I'll send those out along with the minutes. So thank you
Okay.
again for joining us,
Thank you.
everyone. The
Thank
next
you.
meeting is on February the 24th, and Shara Dresstrab from the Office of Rural Health at Montana State University will be joining us to talk about her program. So again, Melanie and Karen, thank you for a great presentation, and thank you all for what you do every day to take care of those in need. Good day.
Thank you. All right. Have a good day. Bye-bye.
Bye-bye.